I guess by way of introduction, well, we tend to blame this sort of thing on Descartes, who was one of these sort of early philosophers who sort of pushed for a sort of splitting between mind and brain back in whenever it was, sort of 16th, 17th centuries. And ever since then, we've had sort of medical systems that are based largely around different organs of the body. And you sort of have your heart and your liver and your brain, and it's all kept sort of quite separate. And of course, that then sort of leads into care systems, which likewise are separated. And it makes it quite an uphill struggle because those in turn sort of translate into data systems. So in England, we have the kind of problem of, well, there's the mental health trusts and there's acute trusts and there's primary care, and it's all sort of rather separate. So when you're trying to bring data together, it can be quite a complex business. And I guess kind of sort of cutting across that has been this sort of growing awareness of multimorbidity. And there was certainly a few years ago, you could hardly move for funding calls for multimorbidity research. And it seemed to be everything. I practice as an old age psychiatrist, and it was all a bit bemusing because I've spent my entire clinical practice treating people with however many sort of health conditions all at once. It's the sort of bread and butter of anyone who works with populations above the age of 70 or so. And likewise, the sort of, I suppose there's a related construct of frailty, the related sort of issue of polypharmacy. So mind, body, brain, well, we know quite a lot about the body and brain bit, I suspect. And of course, that goes in two directions. So we have things like sort of inflammatory hypotheses for depression, or sort of at the older end of things that are vascular depression, vascular dementia, the sort of relationships in that direction. And then, of course, there's a important relationship going the other way, the sort of growing awareness of physical health inequalities in people with severe mental illness and other mental disorders, or at the older end of things, the sort of impact that dementia can have on the physical system and frailty. But that's all, it seems sometimes research-wise, as kind of rather brain and body. Quite how mind comes into it is an interesting one, perhaps one we can, I'll sort of leave you to sort of think about whether you want to discuss that at the end of the symposium, try and think of a good sort of philosophical question that'll keep everyone busy. But in the meantime, let's have presentations. So Alex Kwong, I think, is up first. COVID's obviously been rather uppermost in all of our minds, and very good to see some data science research coming out on that. There's plenty of it, but Alex is going to present on that particular topic. Thank you.
Yeah, thanks a lot, Rob. I'm just going to hand over to Ellen because Ellen's going to lead the first part of the presentation, and then we're going to switch halfway through. So I'll pass it over to you, Ellen.
So what we wanted to talk about today was really the work we've been doing as part of the National Core Studies Longitudinal Health and Wellbeing programme. And I'll talk a bit about the programme as we go through, but really some of the primary questions that we've had when working on this programme is around sort of examining mental health inequalities during the COVID-19 pandemic. So just to introduce the National Core Studies Longitudinal Health and Wellbeing programme. So this is a UKRI funded initiative, which sort of was brought about during the initial part of the pandemic. And the aim of this was to bring together longitudinal population-based studies in the UK, as well as data from electronic health records, in order to sort of answer questions about the direct and indirect impact of the COVID-19 pandemic. And as part of this programme, there were different themes. And one of those themes that we'll be talking about today was the mental health theme. So within that, we were interested in a wide range of questions to do with things like the impact on individuals with poor mental health, changes in the population in terms of mental health, from pre-pandemic all the way through to like sort of through the first and second wave of the pandemic, thinking about things like widening inequalities, health-related behaviour, and the consequences of COVID-19 in itself. And just to highlight, there's a website where you can find lots of information about the programme, and we can post this in the chat, and you can see it here on the slide. And we just also wanted to highlight as part of today that this has been like a fantastic opportunity to use a wide range of data sources, high quality data sources, both from UK population-based studies and electronic health records. And just to say, you know, all data sources have strengths and weaknesses, but by triangulating this evidence and using information across data sources, we've been able to sort of make sure that findings are more robust, and talk a bit about that as we go through. And the way just to highlight the way the NCS works is that we're a big, cross-institute collaboration. So there are multiple researchers involved, multiple analysts across different cohorts or population-based studies. And how it's worked so far is that each analyst tends to analyse data from the cohort that they work with, or the study that they work with. And then we bring those together and coordinate analyses and run meta-analyses and stuff like that. And just to sort of highlight who's involved to date. So as I mentioned, a wide range of population-based, both heterogeneous and homogeneous age studies are involved. So there's the national cohorts, birth cohorts in the UK, like the Millennium Cohort Study, and there are also sort of age heterogeneous population-based studies like the English Longitudinal Study of Aging and Generation Scotland involved, as well as electronic health record data, so Open Safely and SAIL and many other sort of resources have been involved in this effort. And also just to note the sort of host of institutions that are included in this effort. Okay, so down to the data. So one of the things that we were initially interested in as part of this work was looking at sort of the unequal impacts of individuals who had poor pre-pandemic mental health problems. So what we did with longitudinal population-based studies is that we looked at data that was collected prior to the pandemic, and in particular data on mental health. So we wanted to look at whether those with poor pre-pandemic mental health, whether they had a likelihood of developing different types of disruptions throughout the pandemic. And the three types of disruptions we looked at were healthcare disruption, and in particular sort of medication access, procedures and surgery and appointment. We also looked across economic disruptions and across housing disruptions. And what we found was a significant increase in likelihood of experiencing healthcare disruptions for those who experienced pre-pandemic psychological distress. And we also found a significant increase in experiencing economic disruptions, and in particular, the loss of income and loss of employment. Sorry, that should also be highlighted for those who experienced pre-pandemic distress. We didn't find any significant association for housing disruption, so I haven't added that here, but I just wanted to note that in particular. As part of this work, we also looked across cumulative disruption. So as I just mentioned, we looked across healthcare disruption, economic disruption, and housing disruption. And we found that for those who had pre-pandemic mental ill health, they had an increased likelihood of experiencing one type of disruption, and an even stronger increased likelihood of experiencing two or more disruptions, and this was compared to no disruptions. So this is really sort of important information because it indicates to us that there are inequalities for individuals who experience mental health problems, and in particular those who had pre-existing mental health problems before the pandemic. So we're really looking at the directionality here. We're not looking at the impacts on mental health of the pandemic. We're looking at people who already had pre-existing mental health problems and then how that's impacted their experience throughout the course of the pandemic. And it's really important to highlight this to policymakers and think about the impact that some of these things are having on people and how we can prevent sort of some of these inequalities from happening. So the second piece of work I wanted to briefly just talk about was this paper that we've got looking at the risk of long COVID. And one of the things we were interested in part of this work, alongside other factors, was pre-pandemic mental health. So I just wanted to highlight as part of this work that we're using the National Institute for Clinical Evidence definitions of long COVID. And that's those who experience symptoms for 4 or more weeks are classified as having long COVID. And as part of this work, we looked across 10 longitudinal studies as well as electronic healthcare records. And what we found was across longitudinal studies, those with pre-pandemic psychological distress were 46% more likely to experience more than 4 weeks of symptoms compared to those who reported 0 to 4 weeks of symptoms. So this is our sort of long COVID group. So we're indicating here that those with pre-pandemic psychological distress are more likely to experience long COVID than not. And one thing I wanted to highlight as part of this work was that this evidence was shown consistently when synthesizing the effects across cohort population-based studies, as well as in electronic healthcare records. And I'm just specifically talking about the mental health finding here, but this was the case for a lot of the things we looked at as part of this work. And I think that triangulation of evidence and this replication of findings across 2 different types of data resources is really meaningful here, because although we ascertained the measures in slightly different ways across these resources, this consistency is sort of strengthening the findings. Okay, right, I'm now going to hand over to Alex. Alex, if you want to just shout to me to change the slides, I can do that for you.
Thanks, Ellen. So yeah, just following on from this is the next stages of our cross-collaborative work. And at the beginning of the pandemic, there was a lot of emphasis on trying to track changes and the nature of changes of mental health throughout various stages of the pandemic. And I think that's still really important to monitor, because obviously we're still in the middle of it. Things are not necessarily getting any better. So it's important to make sure that we're tracking mental health concurrently to make sure that any changes in mental health can be observed, to work out who needs to be seen, who needs to be intervened and prevented with. So what we've got here is quite relatively recent data, just showing trends in poor psychological distress across multiple cohorts, across the longitudinal studies that Ellen described earlier. And just on the left and sort of the age, we have left age heterogeneous cohorts and then age homogeneous cohorts as well. And what we can see is that there's quite a lot of individual variability between the different studies. So not everyone's reporting high increases and decreases. And it kind of goes back to what Ellen said at the beginning, is that no one study will have, we be full of, we won't have any biases, or when some studies will have their own strengths and their own weaknesses. And what this is all about is just pooling the studies together to get a more global and consistent effect of how mental health might have changed throughout the pandemic. And what we see when we meta-analyze across different periods is that in comparison to pre-pandemic levels, we have seen that psychological distress has increased across the pandemic. And this seems to be highest around the winter months, of winter of last year, early this year, with the highest proportion of people experiencing poorer mental health. If we go to the next slides, this might not necessarily just be, so these are population levels, and of course population levels mask within individual subgroups. So actually what we also wanted to do is identify specific socio-demographic inequalities within these populations. And what we've done is we've stratified by different groups at these different occasions to try to get a more global picture of what's going on across the population, and then what's going on within the population as well. And so whilst we see this increasing in poorer psychological distress, it's not the same for everyone, but there are specific groups who may be at heightened risk. And this includes women, for instance, those in higher education, and not shown here, but younger adults, so those between sort of 16 to 24 and 24 to 35 and things. So quite young groups who may have been differentially impacted through various different mechanisms, which we're still trying to explore. But the point here is to show that it's not the same for everyone. There are different groups who are at risk and may have may require further intervention or preventions going forward. If we go to the next slide. And then some other work that we're just doing now, and we're just trying to put the finishing touches in, and these are preliminary results, so don't read too much into them at the moment. But what we're just trying to do is look for potential mechanisms in which we could potentially improve mental health in the case of subsequent lockdowns, hopefully not, but in case there are future pandemics as well. And what this essentially shows is that what we were looking at were changes in routine health behavior. So things like changes in sleep, so increases in sleep or decreases in sleep during lockdown, or changes in exercise, increasing or decreases in exercise, and just trying to work out across the multiple cohorts that we have at our disposal, whether or not changes in these health patterns are associated with poorer mental health at the same time and poorer mental health going forward, with the idea that if you could sort of promote better health behaviors, so better sleep patterns, better exercise, that may actually prevent or reduce the impact of poorer mental health downstream. So what we have here is just some preliminary results from some of our cohorts, just showing that those who reported a decrease in sleep were 1.79 times more likely to have higher levels of depression following lockdown. But on the flip side of that, those who reported increases in exercise during lockdown were less likely to have poorer levels of depression, so much likely to have better mental health. But of course, I said this is preliminary results. We're adding more cohorts as we're going on. This is sort of the focus of our mental health theme now, just as we move on to the next stages. And if we go to the next slide, Evan. So those aren't the only things that we've been working on. This has been quite a tough period of everyone's lives and everything, and we're trying to sort of consolidate and bring together all the work that we can try to help understand what's going on and who is particularly at risk. Some of the work that we're focusing on now is looking at lone households. There was some evidence coming out at the beginning of the pandemic that people who lived by themselves or were, people who were isolated by themselves were more at risk of poorer mental health. That's something that we're now bringing together across our cohorts and across the electronic health records. One of the main packages of work that we're looking on is the mental health consequences of COVID-19 infection. We know that people with poor mental health are more likely to report long COVID, and there are lots of other studies not done by our work, but showing that people with poorer mental health are more likely to contract COVID. We want to know, is that the same thing as the bi-directional relationship? People with poorer mental health are now going to have, people with COVID-19 are more likely to go on to have poorer mental health, and trying to accommodate some of the biases in the previous research from that. And some of the work that we've just seen, that we've just been talking about earlier, not on this call, but at an earlier meeting, looking at changes in work patterns, so working from home, and is that going to have detrimental long-term effects for mental well-being, and lots more to follow. So if you are interested in this work, do please look at the link that we posted earlier, just to get an idea of what we're up to and the various different work packages. This is all about mental health, this particular work stream, but as Ellen said, there are various different ones, so vaccination, long COVID, other forms of health and society, and other inequalities that we're exploring as well. And if we just go on to the final slide, I think we just want to acknowledge a lot of the researchers who have put a lot of time and a lot of work into making these results come to fruition across multiple institutions, as shown at the bottom there. We're working on a lot of different projects. If you are interested in collaborating, then it might be worth emailing Pravitha Patilay, whose email is just here. She wanted to be here today, but it's not. If you are interested, then please feel free to drop us an email. And I think we'll pass you back to you, Rob, and answer questions at the end. Thank you very much.